Hi, good morning, everyone. I'm Alice Gu from the CDC, and it's a great pleasure to be able to present to you today of an analysis that we had done recently that's been published. I'm going to be describing the association between socioeconomic status and community-associated Clostridioides difficile infection. I don't have any conflicts of interest. So Clostridioides difficile infection, or CDI, is increasingly reported in the community in patients without recent hospitalizations or long-term care facility stays. As early as mid-2000s, there were severe cases of CDI reported in healthy persons living in the community and in peripartum women. Some of the earliest data that we have on the incidence of community-associated CDI come from the state of Connecticut and Philadelphia. During 2005 and 2006, they had conducted surveillance for community-associated C. diff and estimated there were about 6.9 to 7.6 cases per 100,000 population. Interestingly, some of these cases were associated with NAC1, or what we refer to now as ribrotype 027, the epidemic strain that has been shown to produce more toxins than other C. diff strains. And then about a quarter of the patients lacked traditional risk factors such as advanced age, healthcare exposures in the preceding 12 months, and a third of the community-associated CDI cases had no recent antibiotic use. CDC began population-based surveillance for C. diff in 2010 through the Emerging Infections Program. So in 2010, only about a third of all cases reported to the Emerging Infections Program, or what I'll refer to as EIP, only about a third were community-associated. But about 8 years later, in 2018, you can see that now more than half are community-associated. So extrapolating EIP surveillance data to the national level, we're able to estimate the national burden of healthcare-associated CDI and community-associated CDI. So what you see here in the figure on the left, the solid line represents the estimated national burden of healthcare-associated CDI from 2011 through 2017, and you can see that appears to have decreased. And then after we adjusted for test type, specifically nucleic acid amplification test, or NAT, which is higher sensitivity for C. diff, we found that the adjusted national burden of healthcare-associated CDI decreased by 36% during this period. In contrast, in the figure on the right, you can see that the national burden of community-associated CDI appeared to have increased from 2011 to 2016, with a slight decrease in 2017. However, after adjusting for test type, the adjusted national burden of community-associated CDI remained essentially unchanged during this period. Now, this may not seem that concerning until you consider the fact that healthcare-associated CDI has declined, whereas community-associated CDI has not. And now we have nearly as many community-associated CDI cases as we do healthcare-associated CDI cases. So what do we know about community-associated CDI? Well, it tends to occur in younger population. The incidence of community-associated CDI is higher in the age groups 1 to 45 versus older age groups. It generally has milder disease and clinical course than healthcare-associated CDI. About a third of community-associated CDI cases do require hospitalization. However, only about 13% experience a first recurrence rate versus 17 to 20% of healthcare-associated CDI. And only about 3% experience in-hospital death versus 8% of healthcare-associated CDI. Despite the milder clinical course, the national burden of community-associated CDI hospitalizations and first recurrence episodes is still substantial. There were nearly 70,000 hospitalizations and over 31,000 first recurrence episodes in just 2017 alone. And I think this highlights the importance of identifying effective prevention strategies to reduce community-associated CDI, like we have done with healthcare-associated CDI. And so studies that looked at risk factors for community-associated CDI have found that antibiotic use remains the primary risk factor. However, only 40% have had recent antibiotic use. 80% of community-associated CDI patients had recent outpatient healthcare exposures. In fact, in a case control study that CDC conducted, we found that a recent emergency room visit was associated with community-associated CDI. So while outpatient healthcare exposures may be a driver for community-associated CDI, not all patients, however, have this exposure. In addition, white patients have been found to be at increased risk for CDI. And some studies have attributed the racial differences in CDI to white patients having greater access to healthcare, leading to increased antibiotic exposure. However, it's not clear what other social determinants of health might influence the spread of CDI in the community. To date, I'm only aware of a handful of studies that have assessed the relationship between CDI and health disparities or socioeconomic status, what I'll refer to as SES. And most of these studies have focused primarily on patients hospitalized with CDI or hospital onset CDI. I'm aware of 2 studies at least that have tried to look at community-associated CDI. So one study was conducted in Bernalillo County in New Mexico, and they found that communities with high percentage of individuals lacking health insurance with low percentage of individuals with low educational attainment were associated with increased community-associated CDI incidence. Another study was conducted in Australia, and they found that neighborhoods in Southeast Australia that were socioeconomically disadvantaged were positively associated with community-associated CDI. Now, you'll notice those 2 studies I described included area-level SES data in their analysis. And it's a common approach that investigators use when individual-level SES data may not be available. And oftentimes, individual-level SES is not collected in population-based surveillance or research studies because it's considered sensitive data. Even if patients were interviewed and directly asked for this information, they may decline to provide it, such as income, they may not want to share that information. However, residential addresses are often collected, and we can geocode addresses to census tracts and link to SES data at the census tract level. I'm sorry, I can go back, thank you. And so, there have been studies that have compared the use of census tract level SES data with other area level data, such as county level. And census tracts have been shown to have greater precision for approximating to individual level SES values. So using a similar approach as the other 2 studies, for our study, we sought to identify community-level SES variables associated with increased community-associated CDI incidence using population-based CDI surveillance data from CDC's Emerging Infections Program, or EIP, and using census tract-level SES data from the American Community Survey, or ACS, and from the Health Resources and Services Administration, or HRSA. So first, a few words about EIP. So for those who aren't familiar with CDC's Emerging Infections Program, it's a network of health departments and academic partners in 10 states, as shown here on this map, shaded in dark blue with a star on it. EIP conducts active population and laboratory-based surveillance for several infectious diseases, including CDI. And so what this means is that for all residents in the surveillance catchment areas, any positive C. diff test result, whether it's obtained in the hospital or as an outpatient, gets reported to EIP site staff. So EIP started CDI surveillance in 2010, initially in 7 of the 10 states, and then expanded to all 10 states in 2011 in 35 counties of these 10 states, with a total surveillance population of over 12 million people. Next slide, please. So for this study, we determined the census tract level incidence of community-associated CDI. We were using 2014 and 2015 data at the time. And to do this, we determined which of these were community-associated if they met the following case definition. If the person was at least 1 year of age with a positive C. diff stool specimen collected either as outpatient or within 3 days of hospitalization, and no positive tests in the prior 8 weeks. So we only wanted to look at incident episodes, and no overnight stay in a healthcare facility in the prior 12 weeks. And they were able to geocode it to the census tract. And then using population estimates from the US Census Bureau, they were able to estimate or calculate the incidence of community-associated CDI at the census tract level. So in total, there were 2,474 census tracts across the 35 counties in the 10 states. And the incidence ranged from 5.8 to 470.7 cases of community-associated CDI per 100,000. We obtained the census tract level SES variables mainly from ACS, although we did obtain one variable from HRSA. We chose the census tract level SES variables based on previous studies of health disparities and known risk factors for C. diff. And so the variables that we initially selected included variables to do with income, so percent of households with low or high income receiving public assistance income, persons below the poverty level, unemployed. We also had a variable about crowding in the house, expensive homes, as well as low education and high education. We also had a few variables related to foreign-born, so foreign-born status, poor English speaking at home. We also had a variable about new mothers and several variables about health insurance. So overall health insurance, or having public health insurance, private health insurance. And then from HRSA, we also obtained data on whether or not the census tracts were part of a medically underserved area. So as I mentioned, our objective was to identify, determine which of the SES variables were associated with high incidence of community-associated C. diff. However, we soon discovered that many of the SES variables were highly correlated, which precluded us from including all the variables together in a single model to identify their independent association with community-associated C. diff. And so to overcome this challenge, we utilized a method known as exploratory factor analysis, which is a method that apparently is more commonly used in behavioral studies. And what this method allowed us to do was to identify the smallest number of factors to explain the variance among observed SES variables. So in other words, it allowed us to group variables that are the most similar to form a composite variable, if you will, which we'll call a factor. And those variables that did not load well on the factors or load on more than one factor were excluded from this factor analysis. We then calculated factor scores for each census tract, which was computed as a weighted combination of the contributing SES factors for that factor, SES variables for that factor. So this slide now shows the results of the factor analysis. We were able to come up with 3 composite factors. So factor 1, which we'll refer to as poverty, included variables related to low income, poverty, public insurance, unemployment, public assistance income, private insurance, and note that private insurance was negatively associated with factor 1. Factor 2 was composed of less English speaking at home variable, foreign-born status, and crowding in the homes. And factor 3 was composed of high income, expensive homes, and high education. Note that both low education and health insurance loaded equally more than one factor, and new mothers did not load well at all, and these were excluded from factor analysis. So after controlling for age, sex, race, antibiotic, and NAT usage, we found that poverty factor and foreign-born factor were significantly associated with higher incidence of community-associated C. diff, whereas the high income factor was significantly associated with a lower incidence of community-associated C. diff. So in other words, what this meant was that communities with lower SES had higher incidence of community-associated C. diff. Specifically, neighborhoods that had households with low income or receiving public assistance income, or neighborhoods with residents living below poverty level who are unemployed or who have public health insurance were associated with higher incidence in community-associated C. diff. In addition, neighborhoods who had foreign-born residents or spoke less English at home or with crowding at homes were also associated with community-associated C. diff. So what do these findings suggest? Well, perhaps living in a low SES area could be a proxy for the types of outpatient healthcare exposures that might increase the risk of community-associated C. diff. We know from a previous study that census tracts with higher percentages of uninsured residents had higher incidence of community-associated C. diff. We also suspect that uninsured persons, or maybe even underinsured persons, may be more likely to use emergency rooms as their main access to healthcare. As I mentioned earlier in our case control study, we found that visiting the emergency room recently increased risk for community-associated C. diff. And so, emergency rooms might be a potentially high-risk setting for facilitating the spread of C. diff because they have higher patient volume with increased potential for exposure to symptomatic CDI patients who may be shedding more in the environment. And with a high patient volume, the need to turn rooms around quickly, there might be inadequate time for appropriate cleaning and disinfection of the environment. Our finding of household crowding being a socio-community-associated CDI is consistent with other studies that have found this as well. C. diff persists in the environment and can potentially spread more easily in crowded living conditions where strict adherence to hygiene precautions may be suboptimal. And then in studies of households of CDI patients, up to 13% of household contacts, as well as several household environmental samples, most commonly the bathroom, were found to be positive for C. diff. We also know that asymptomatic carriers can be a source of community-associated C. diff, and in a crowded household, they could potentially increase person-to-person transmission of C. diff. So interestingly, we found that neighborhoods with foreign-born populations had higher incidence of community-associated C. diff. And so why might this be? And so, we're hypothesizing that perhaps households that spoke less English might have lower health literacy due to language barriers. Perhaps they have less understanding of the risk of CDI associated with antibiotic use. There may also be cultural differences regarding outpatient healthcare utilization or diet that could potentially increase CDI risk. There might be differences in these neighborhoods with respect to the availability of certain types of foods as well as affordability of foods. We know that C. diff has been isolated from several different types of foods, although the effect of diet composition on CDI susceptibility is unknown. There were several limitations with our study that I wanted to mention. Because this was an ecological analysis, no direct causal relationship can be assumed. We also had cases that were diagnosed by NAT alone, and they may have only been colonized with C. diff instead of having actual disease. So it's possible we may have overestimated community-associated C. diff incidence. And it's also possible that some of our cases may actually have been healthcare associated and may have been misidentified as community-associated because of incomplete medical records where there was lack of documentation of prior hospitalizations. Although we were able to transform highly correlated SES variables into distinct factor scores, we did not know the relative contribution of each SES variable to that factor. And so we weren't able to determine which SES variable was most highly associated with community-associated C. diff. Next slide, please. So in summary, communities with low SES were found to be associated with higher incidence of community-associated C. diff. And I think additional studies are needed to determine whether this association is the effect of an individual being impoverished or living in an impoverished area regardless of their personal income, or whether it represents a combination of both effects. It's important for us to better understand how SES factors may impact community-associated C. diff, since that would help us better target our prevention efforts in these higher risk areas. I just want to acknowledge the many co-authors of this analysis, this investigation, and I want to specifically highlight Kim Skwerbarsek, who was a former Epidemic Intelligence Service Officer in our division who helped lead this analysis. Thank you. So let Dr. Kutty go.
Good morning, everyone. And I would like to thank Christian and the team and Peg Lillis Foundation for this opportunity to present. I'm here for a few minutes just to provide an update on C. diff infection and the antibiotic resistance and patient safety portal. Christian has always invited us to these summits, and it has been great to provide updates. We've also taken a number of feedback from this group, and it also helps us to think about what next steps. So I have no conflicts of interest. So just to start with the guiding principles of antibiotic resistance and the patient safety portal, it's, we are very focused on the mission to get, to listen to our stakeholders and to, have the numbers available to our stakeholders. And we are very much aware of the users who use this, and we do want to work with them and collaborate with them as at the end of the day, this data is really important, just not for CDC, but the public in general. So on each of these slides, you'll actually see a link at the very bottom that describes the web page that I'm relating to. So when you do have the time, I would encourage you to visit our website. So when you do reach out and when you do click on the link, the landing pages, covers a broad variety of what we would like to present. So it contains antibiotic resistance, antibiotic use and stewardship, healthcare-associated infections, the geographic locations, and featured items and data stories. So because this talk is focused on C. diff infections, I'll just go through very quickly. You have already seen a presentation of the C. diff infections before on this web page, but our goal is to make C. diff count. We have heard many a time, that highlighting C. diff is really important, and we definitely have listened. So I would like to go through a couple of updates we've provided. So when you do reach out to the C. diff infection, you are able to see some of the data. This is just a snapshot, partly because, we have the National Healthcare Safety Network data currently on our website. And so the focus, when you do land, you'll realize that the numbers are all related to the NHSN data. And as you click through each of the data, you'll also identify that there are small boxes of information that I would suggest, also exploring. I think they do give a better data and sort of better nuances as to how this data is presented. And because Allison presented EIP data, we thought it would be nice to connect some of the data. So NHSN captures the hospitalized individuals, right? So they may get the infection either from the community or from the hospital and can be further categorized in that way. On the EIP side, they present the community aspect, but they also capture those individuals and the sources of infection. So you can, at some point, explore this. I won't go into detail today, but this is just a slide for you to think about or try to understand a little bit more how NHSN and EIP sort of merge sometimes, so how the cases fall into place. So the current CDI visualization, based on your feedback, current hospital has hospitalized infection calculations. And this is based on hospital onset CDI infections and community onset inpatient infections. And so when you do, as you explore the C. diff website, you'll see there is a geographical map. And as you hover over each state, you find the SIR, as well as the hospitalized infections that you can obtain. And just to give a clearer picture, and as per, at state level, we have actually, this is just a mock-up. We are planning to bring this on board soon, is to provide these infections in a bar chart and a graphical way. On the left side are opportunities you can look by state. And as you, explore, you'll find that each state is provided and that the graph actually changes as per state. So while the geographical map was sort of to give you a big picture, this bar chart will actually give you a deeper dive. Again, this is all NHSN data that is presented. And as CDC and the rest of the world moves towards more about socioeconomic status and the various demographics, we are also adding the About section section to this. And this will be found in the geographical location that talks about, the census. We'll also have a little bit more sort of information about the number of hospitals that are present in that state. But please keep in mind that as you do explore the website, also seek to look at where the data sources are, because there are a variety of data sources available on this website. This is my last slide. I just want to thank everyone. Again, Christian and team, thank you for the opportunity to present and provide an update. And I also like to thank ARPSB team for creating this, as well as DHQP for having a vision to get this to our stakeholders. Thank you. And if you have any questions regarding ARPSB, please feel free to reach out to the email provided on the slide. Thank you.
Well, thank you both very much. That was really interesting. So I think, so I don't think in general that we talk enough about poverty in this country. Our elected officials talk a lot about middle class, and we don't talk about poor people. And we were really poor when I grew up. My mom was on welfare after my parents split, and we were on school lunch, and I went to college on Pell Grants, and so we were definitely in that socioeconomic status that Alice was referring to. So I'm really glad that CDC and other researchers are looking into the relationship between these two things, because we do know that a lot of endemic pathogens tend to disproportionately affect the poor and the elderly. And Dr. Kutty, sorry, I'm like, do I have first names? Doctor? I'll use first names, is that cool? And Preeta, thank you so much for the preview of those visualizations. I think something that we struggle with as advocates is having great ways to kind of capture people's imaginations and help them understand like the sheer number of infections that we're dealing with, and then to humanize those infections. And so I think this new visualization is going to be a great way for us to do that. So we do have a few questions that have come in so far. And please, folks, if you have additional questions for either Dr. Kutty or Dr. Gu, feel free to enter them to the chat. So we'll get started with my Aunt Helen, who's a board member, asked, she wasn't sure if she was reading it right, but in Dr. Gu's presentation, is the high FEMA number related to anything specific?
Yeah, so that's a really great question. I mean, consistently, we've seen a higher incidence of not just community-associated, but C. diff in general in females compared to males. And, I don't know if anyone's fully been able to elucidate or understand exactly why, but it might be due to several factors. I think, one hypothesis is that there might be differences in the gut microbiome between females and males, and maybe hormones might be at play here as well in terms of the interaction with the gut microbiome. But, there also might be differences in the degree of healthcare utilization between males and females, that definitely warrants a bit more further exploration to try to figure out why there is this difference.
Thanks. Yeah, I mean, we definitely noticed, I've noticed that over the years in looking at the research that there's a slight disproportionality. It could also be that women utilize healthcare more than men. I mean, there's try getting your husband to go to the doctor, right, ladies? Or gentlemen, because my husband's very good about it. He goes as he's supposed to. So next question is from Jose Estrada, and he asks, can you speak to the severity and mortality associated with C. diff in low socioeconomic status settings?
That's also a really good question, and maybe that's something we should try to do, as a next step. This analysis we did was kind of like our initial attempt or initial foray, if you will, to try to understand what are the SES variables, potentially associated with community-associated C. diff. We did not look beyond just looking at the variation in incidence of C. diff to, look at understanding, whether there are differences in C. diff mortality and severity of disease. That will probably be, additional steps that we need to take in the future. So, but that's a really great question, and something we can certainly add to our to-do list.
Yeah, I mean, there was a new study that came out a few weeks ago that looked at the relationship between multiple recurrences and both the likelihood of going into septic shock and also having a colectomy. And I didn't dig into like who the population was, but it did make me wonder if if people are getting suboptimal care, if they're getting care from like minute clinics, like if they don't have the kind of healthcare where like they have a really great doctor who's following them or access to an academic medical center, are they kind of being just given vancomycin and sent home again? And that can be related to people's socioeconomic status as well, like, and also where they live. Like there's we know there are places in this country where the nearest acute care hospital is 2-hour drive away. So there's a whole range of factors that could be playing in this.
Yeah, and I wanted to add to that, and I'm sorry, there's a lot of yard work going on outdoors.
It's
So
okay. I had people throwing out garbage outside of my window during my presentation. So,
but I want to mention that's a really good point that you mentioned, Christian, because that's something that we actually are just discussing here at CDC about looking at our treatment data again and trying to understand if we could link it to SES variables to see, if there are predictors for why some people are getting suboptimally treated versus others, and does it have to do with, as you mentioned, like if someone doesn't have insurance that can cover, say, fidaxomicin or oral vancomycin, is that going to affect why they end up with metronidazole instead? So, so just letting you know that that's an area of interest to us and something we definitely want to look into further.
Yeah, I have another question, but I'll just share this couple that I helped recently. They lived in Tulsa, outside of Tulsa, Oklahoma, and he was 78 years old and was recovering from a stroke, and she is 75, and he had C. diff 4 times while in the hospital recovering from the stroke. He was transferred to a rehab center where he had C. diff twice. Then he was sent home and he had C. diff once again, and he was on his 8th bout of C. diff when his wife, through her dogged searching, found my cell phone number and called me. And at no point were they offered anything besides additional vancomycin. They were not told about even fidaxomicin or an FMT. And so I worked with her quite a bit, even talking to her pharmacist, like on the phone, and so I think that partially it's also like, what are the healthcare systems that you can access and how up to date, we know there are hospitals across this country that don't even have an infectious disease doctor on staff. So, there's a whole range of potentiality that we just need to understand better, and so I'm just really glad that you guys are beginning to dig into this, because I think it's something, we've seen in the most horrific fashion how COVID has disproportionately impacted seniors and, people that must go to work, that are hourly employees, so I wonder if we're going to see similar correlations when you dig into that. All right, so one of our board members, Gerard Honig, has an incredibly technical question that I will read to you. So he says, 5.8 over 400 seems like a very wide geographic variance for a relatively common health condition. Is this level of variability expected for conditions heavily impacted by socioeconomic inequality?
Yeah, that's also a very interesting. So this is, like I said, we're just starting to look into SES in general, even for our division in terms of healthcare associated infections. It's not a topic that we have a lot of experience with. So, I can't speak to, other conditions, if you expect this wide of a variability in incidence for other conditions. But for C. diff, I think this is actually helpful because, it does show that there is variability, between census tracts. And so the fact that we found statistically significant findings associated with, certain SES variables suggests there really might be a difference. If most of the census tracts are very similar incidence, if the range was a lot narrower, then, one might actually argue that maybe you wouldn't see as much, like maybe it's not as affected by socioeconomic status. So I'm actually, pleased that we, found what we found. And so again, next step, try to explore this a little bit further and better understand, what our findings actually are pointing to. But I appreciate this question, and it does help us think about our analysis a little bit more and maybe refine our analytical methods for, the next time we do something like this.
And this is a question for both of you that is just coming to the top of my head, but do you envision in the future, you've given us a preview, Preeta, of some new ways to visualize data for C. diff that's coming to the CDC's website, do you envision being able to look at things, to break things out by things like socioeconomic status or gender or race or age in a way that might be able to help people understand those disparities?
Yeah, and a good question, Christian. It's actually interesting. I mean, part of it, we are having ongoing discussions with Alice and the team to bring the EIP data into, into ARPSB. One thing we really are looking forward to is bringing the race ethnicity data, and that, we're trying to discuss how best to present it. But yes, as Alice and her team explore the socioeconomic status and until we get to a really good point that we are comfortable, we're definitely open to bringing that on board as well.
Well, you want to make sure it's accurate.
Yes, definitely. I mean, our goal is, to bring as much of the information we have within DHQP to ARPSB and to our stakeholders. Alice and others within DHQP do an awesome job of sharing this information either through manuscripts or conferences. And then, we want this information to be out there. I'm not sure if Cliff is listening, but, ARPSB is his dream child, and he is, looking forward to sharing everything we have within DHQP and open transparency. So, with that kind of passion that exists within DHQP, I'm sure, it's only a matter of time.
Yeah, we have another question, but I want to take the opportunity because we only have a couple minutes left to say that I first was invited to come to CDC in September of 2012, so about a year and a half after I lost my mom, and a year and a half into this journey. And that was the first time I met Cliff, Dr. McDonald, and met Denise Cardo, and just, I could name a bunch of other people. I don't know if I met each of you at that point, but I did it in the intervening years. And I have to say that CDC and the Division of Healthcare Quality Promotion in particular has been incredibly responsive to patient advocates. I've seen the change over the past 8 or 9 years in terms of, you hearing feedback from us, you working with us to kind of make information more presentable and more useful to those of us who are out there advocating. And it's something that I notice, that I hear other patient advocates talk about, and so it is greatly appreciated. Because, especially over the last year, God, you've all been in my thoughts. Of just doing an incredible job in an incredibly difficult environment. So Gerard has another question for Dr. Kutty. Does CDC have the ability to track how these resources, the data analytics, are used? And have you seen an interest and engagement post-COVID, like with the ASPS? And you may not know the answer to that. There may be somebody else who's doing the analytics.
We certainly get, people do visit the website. But I think the focus has been so much on COVID that, everything that is COVID related seems to garner a lot of interest. Recently, in terms of just to give, when we are updating documents, we did come across a couple of articles that look at COVID and C. diff. So those are the things that we would like to highlight on our website. That's our goal. We're trying to think of ideas of how to do it. So certainly we welcome, ideas from the advocates, from the public. We also are very much aware, like, Christian said, these are numbers, but to each of us, they're actually people, right? They represent a loved one. And that's a message we want to get across to everyone. These are just not numbers, but these are actually people.
Yeah, well, we don't have any questions, so I think that's a great place to leave it on that note. I want to thank both of you so much for taking time out of what I know has been an incredibly busy year and days, and I'm sure you're all overworked and underslept and undernourished at this point. So it really means a lot to me personally, and I think speaks very well to just the commitment that CDC has to C. diff and healthcare-associated and antibiotic-resistant infections, which, you know, many of us are beginning to think, like, is that the next pandemic, where we just reach a point where we run out of treatment options, and so things that were manageable are no longer manageable. So yeah, and you know, each person, whether it's C. diff or COVID, you know, it looks like statistics, but there's a person behind every one of those deaths and those cases, and those, you know, not just affect the person who passes away or the person who's sick, but it you know, reaches out into their families and their communities. So thank you so much, both of you. We really appreciate it. I'm going to let you guys go back to, I'm sure, a very busy day. I do hope to get to see you in person at some point in the next year or so, once everyone's vaccinated and we can move around a bit. But thank you again so much for being here.
Thank you. Thank you very much.